Good afternoon, friends. Namaskar to all of you. Indeed, it's a great honor to be here in this Andhra Pradesh Ophthalmic Society meeting, and especially thank you, Dr. Reddy, the President, and my own Dr. C.V. Gopal Raju, and Dr. Madhu for a kind invitation. And it's a real honor to deliver this oration on Professor P. Siva Reddy, who's been a great clinician, teacher of our ophthalmic fraternity in this country. And today, sitting in the audience, Dr. Chandrasekhar, who's received Padma Shri last year. And it was a great honor to listen to you, sir, and very motivating. And I had a pleasure to write a brief few notes when you received Padma Shri as one of the awardees at that time. Congratulations, sir, doing such a wonderful work for our country, which is really needed for not only for a country, but all population which are there in a area which is totally deprived of these facilities. Today I'm going to talk about something which we are working on, and we have worked for last so many years to improve the outcome of surgery, that to a cataract surgery in Indian population, not for India, world over. I think this is one surgery which can really change the outcome of a particular suffering, disease of a person. You can improve the quality of vision, you can improve the quality of life of a person after doing cataract surgery, because a person who's suffering at the age of 60, 70 can become as young as 20 years because of a modernization in cataract surgery and intraocular lenses. We talk about cataract surgery in such a large extent. Today we talk about giving a vision which is as good as refractive surgery in the cornea, or a correction of refractive error in a patient. So we have to really work in such a manner where outcome improves to that extent where you hardly have a complication, and implant the intraocular lens in such a manner where things can improve. So what better can happen if you can image the entire clinical aspect of a cataract, a patient, and do a clinical assessment through imaging during the cataract surgery also. No financial interest from my side for this talk. We all knew how to examine your patients, especially the cataract patient, where examination under slit lamp is the teaching for all of us, which gives you so many details. Like this is one example of a senile cataract, intumescent cataract. You can see the bulging of anterior capsule, you can see shallow anterior chamber, you can see intralenticular clefts. These things can be appreciated in imaging also, because imaging is the authentic, you can say, reporting of a particular system or organ or a disease area, and that is what you see, and can be a real good impression for yourself or patient for recording also. The same picture can be seen in intersegment OCT also. But what is missing here? This image is not a live image, it's a still image for a case. And what better would be there if you do a imaging when you do a surgery also. And that has been possible now with microscope which are integrated with optical coherence tomography system. So these are called AIOCMTC2 microscope, where you can see the entire dynamics of a surgery. You can see what happens to the tissue, a part of a eye where you actually do a particular step of surgery. Incision, capsulotomy, nucleotomy, implantation lens, posterior capsular delineation, the wound delineation can all be appreciated in a very dynamic fashion during your surgery also. The entire visibility can be totally different than what you see through the microscope, which gives only 2D images. To see a 3D images, you require an IOCT microscope. So today I'm going to take you through the two difficult areas or challenging situation in cataract surgery. You all understand wide cataract does give you challenges, poor red reflex, shallow anterior chamber, intumescence, chances of rhexis getting extension to periphery is very, very high in intumescent cataracts. Therefore, imaging, as I showed in the initial slide, where you could do a very nice examination before surgery by doing anti-segment examination by slit lamp, anti-segment OCT. Same can be picturized on the table in IOCT microscope. So these are various spectrum of wide cataract imaging, which we have titrated, seen through the microscope to see and classified them in 4 different types. And you can have a spectrum in between also. These are 4 categories of a wide cataract, which I'll describe how we have done it. There are 2 things. One is the examination through anti-segment OCT or slit lamp. The green ones, the convexity of anterior lens capsule, the arrangements of lamellar cortical fibers, the lenticular cleft, they can all be seen. But what you can see through IOCT microscope is what happens, the flattening of anterior lens capsule when you inject the viscoelastic in the anterior chamber. When you make a nick into anterior capsule, what happens to the entire dynamics of capsule? Does it go flatten? Does it get raised? What happens to the fluid coming through? All these can be seen with a one step of surgery through IOCT microscope. Type 1 white cataract we classified into a very regularly arranged lamellar fibers, minimal intralenticular clefts, and the convexity is not much also. If you make a nick also, nothing comes out. Everything is flat. You can do a nice capsular access, finish your surgery without any difficulty also. We categorize this type of cataract, white cataract, to type 2 intumescent white cataracts, where you had an increased convexity of anterior capsule. You had a thick sheets of a cortical fibers, hydrated one, and intracortical fiber clefts, which are underneath these hydrated cortex. If you make a nick here and release nothing comes out because the fluid pockets are inside the hydrated cortical fibers. And these cortical fibers, they raise like a dome or like a tsunami. If you don't control your surgical step at this stage, the capsule is going to tear to the periphery 100%. So you have to do very small rexes, and these cases can be managed effectively if you do this technique also. This is the example of a type 2 cataract. You can see as soon as I make a nick, entire cortical fibers are getting up like a hill, and this has a tendency to pressurize the capsule and tear will go to periphery. So we have to tamponade the peripheral area, make a small opening in the anterior capsule, aspirate this cortical fiber, not the fluid, cortical fiber, so that you decrease the pressure, make the convexity into concavity, so that subsequently you can tear the capsule very effectively without risking your capsule to go to periphery and complete your phacosurgery in this case. Type 3 is a mixture. You have a hydrated fibers also, you have a fluid also, and when you actually make a nick, sometimes a turbid fluid comes out, sometimes milky fluid comes out, but mostly it is a very light, oily fluid coming out, which per se will decrease the pressure, intralenticular pressure, and you can still do a surgery effectively in these cases also. So these are cases where needle aspiration might help you. The previous case, type 2, needle aspiration doesn't help there because it's a cortical fibers. So you have to actually aspirate with the aspiration methods. This is a type 4, which is totally fluid. We call hypermature cataract or Morganian cataract. You make a nick, and entire fluid comes out and pressure goes down. You can do a nice capsular access subsequently also. Femtosecond laser devices have come in last 15 or 20 years, and that also gives you a nice assessment through OCT, which is there in a femtosecond device also. You can see here, you can picturize the entire cataract. This is the fluid-filled pocket which is there. And this fluid-filled cases give a different challenge in the femtosecond laser. You can see now, this is called a bursting of fluid coming underneath the capsulotomy. These cases can be difficult sometimes. We have to stain them, see the area, skip areas, and manage subsequently. So if you're doing manual surgery, and if you're doing femtosecond surgery, they are totally two different ways to understand these cases per se. So this is how we classified the challenges faced. We know that type 2 may not be amenable to needle aspiration, which we classically teach everyone. If you have an intumescent cataract, aspirate the fluid. So not all cases will have fluid. They can have a hydrated cortex, which may not come with a needle aspiration. So you have to see your patient carefully. I know that many of you will not have access to IOCT microscopes. But what I have shown, that can be translated to your examination of your cases with slit lamp and anti-segment OCT also. So this is what we teach nowadays. If you see a white cataract, always do good examination, perform anti-segment OCT, and if you have IOCT, that will definitely change your concept of surgery during the each steps and manage these cases accordingly, whatever you face during the each step of your surgery. The white cataract is challenging, but it can be managed effectively if you can structurize, picturize the entire morphology of your cataract. Second challenging aspect will be a posterior polar cataract, because we do see posterior polar cataract maybe 1 in 100, maybe 1 in 500 in busy clinician practice. These always have a different presentations like this, multiple presentation there where you may have different challenges. So this is a two-dimensional picture. You can't see what is the status of a posterior capsule in relation to the posterior polar disc. So that can only be seen by anti-segment OCT, which is either your pre-surgery or intra-op OCT or a femtosecond laser device. So this is what you see. You can channelize your examination into seeing the posterior capsule and the disc as such a posterior polar cataract. So these cases can be pixelized. So this is one publication, I think one of the best publication we have in the posterior polar imaging by one of my colleague, Dr. Amar Pujari, where we have delineated the high-risk features or images on anti-segment OCT of these posterior polar cataract. So these are three important images which you can see through the anti-segment OCT, or sometimes you can see with the slit lamp also. The first one is a conical shape, second is a moth-eaten appearance, and third is the eclectic morphology. If you have these three types of morphology, you have a very high percentage chances of a posterior capsule getting opened up during your surgery, and your entire surgery will get messed up. So this is what you have to see. Accordingly, you have to change your surgical pattern, modify your phaco parameters, and do surgery effectively with these patients also. These imaging which I am talking about is not only for phaco surgery. These are important for all types of cataract surgery. It is important for SICS also. There you can modify your surgery accordingly. If you are generalized morphology, you have very less chance of posterior capsule getting opened up during your surgery. So this is very important feature of posterior polar cataract which you have to assess. Same time, we also publish our examination of these cases through intra-op OCT also. There also we could pixelize the similar patterns, and we classify them to 4 types of different cataract based on a clear delineation of posterior capsule underneath the disc and the size of disc as a type 1, where you could see the posterior capsule clearly, and surgery becomes as simple as routine surgery because the PC is clear. You can do hydro procedure effectively in these cases, and surgery becomes very simple here. You can see this is one of the first time you will see that actual separation of fluid happening by hydro procedure. You can see here, now I'll inject the fluid. You just see the IOCT picture. You'll see the fluid wave creating space there. So you have endonucleus and the epicortical cushion. You can customize the cushion for your safety for your patient as you do in a femtosecond laser in these cases. So that is the advantage of knowing what is happening during your surgery with the IOCT microscopes. And these type 1 cases you can do very effectively. This is type 3, where you have a moth-eaten appearance. The entire disc is very, very large, thick, and you have absolute shadowing. You can't see the posterior capsule at all. So these cases are very high chances that posterior capsule can get opened up. There you require a technique of doing nucleotomy where you safeguard the posterior capsule, because sometimes the posterior capsule will be open, or sometimes it might open during your procedure of hydrodissection delineation. The nucleotomy has to be absolutely safe. So this is what we published recently in IGO. The video is available there. People can see there how to do a safe nucleotomy, that is chop and tumble technique. Do a first delineation, one delineation, second delineation, and you'll see that this delineation can effectively translate into 2 separate compartments, endonucleus and epicortical cushion, and subsequently you can do surgery in these patients also. So how to do surgery without rotation? Because rotation is not applicable in a posterior polar cataract, sometimes in a slightly harder nucleus. So do a first chop here, because you can't do rotation because delineation not complete. Take another chop here, take out this piece. So this gives a space for a fluid to go, give internal hydro delineation happening in these cases. Again, second chop. Now I can tumble this piece to the center with my second instrument without disrupting the epicortical cushion. I think this is a very important teaching for all of you to understand difficult cases like a subluxated posterior polar cataract or a post-vitrectomal eyes where you might not be able to rotate nucleus, and do a safe chop and tumble technique, and that will give you access to a nice outcome. This is to represent same surgery with IOCT pixelization, how the fluid goes inside and separates the layers of epinucleus. You can see the various area of separation happening because of IOCT imaging in these cases of posterior polar cataract. And this selective dislodgement of a nucleus from the epicortical cushion without disrupting the epinucleus core is very important for not only for posterior polar cataract, cases with open capsule or patients with subluxal cataract also. So this is one case. You can see IOCT microscope shows that this is a conical shape or may have an open posterior capsule in these cases also. So those cases are always difficult to manage. And these cases has to be managed with effective phaco modulation, power, your fluidics, pressurized IOP, everything has been modulated in a way where you don't change the anterior chamber dynamics during your surgery. Do a capsular access of a size around 5 millimeter, 4.5. Do a hydrodissection delineation. During hydrodelineation, the capsule opened up. You can see this is a flutter happening and capsule opened up. In such cases, or cases where you have pre-existing open capsule, this chop and tumble technique is very, very handy and without disruption. The nucleus emulsification is complete now. I'll take out the epicortex, maintain the anterior chamber dynamics, don't let chamber to get shallow, aspirate the cortex. You can see the tear in the middle here, large tear extending from end to end, which is classically seen in a posterior polar cataract. This tamponading the anterior vitreous face and tear with the dispersive viscoelastic safeguards everything. And you can still manage put the lens in the bag in such cases. If you can able to manage the tear not to extend too much or anterior vitreous face not to get disrupted. So that's a very important teaching here to do a safe nucleotomy in these cases where you have the damaged posterior capsule. Same thing can be replicated. The layer by phaco or a crater and chop in a femtosecond laser. This technique we published way back of a femtosecond laser device where we make 3 rings of safety and 8 chops. And that gives you a layer by layer removal of these blocks, primary, secondary, tertiary block, and safeguard the epicortical cushion again. So this rings of safety and chopping gives very, very effective visualization of procedure. You can see the chops are there, no hydrodissection. Open this chop, the bubbles come out. Then you can take one by one each, you can say a piece, which is blocks we have made with a laser treatment. So laser is also a very effective tool in these difficult cases, challenging situations, wide cataract, subluxural cataract, posterior polar cataracts, and really change the entire concept. The posterior polar cataract, again I'll say, imaging is very important, pre, up, and post-op. If I have to do anterior-segment OCT for my cases of cataract, I'll definitely do for all cases, but especially for posterior polar and wide cataract to see the morphology of these cases. And if you have a femtosecond device with you, these are also helpful in these scenarios also. Other area which most people neglect is the wound construction and its management during your surgery and towards the end of surgery also. This is what we looked into, compared femtosecond wound versus the manual incisions. And we realized that, if you do a nice management of wound, you have hardly any chance of a wound side detachment detachment. But if you do a ragged incision, very dull blades, you can have descending membrane detachment in the wound area and subsequently create a situation where like this. This is a Fuchs patient and I'm completing my surgery in this case. Fuchs patient, you all understand, would have higher chances of descending membrane detachment during surgery or subsequently also. And in such cases, it's very important to see carefully these patients also. So this is the aspiration. You can see little gutty changes in the central area also. I'm hydrating the wound. I realized that some flap was moving. I put on my IOCT microscope to see if this area is all right. Then I realized there's a little detachment in the posterior part. But as soon as I removed my cursor, took towards the central area, then realized it's a very large descending detachment. You can see how large it is. So this had to be managed on the table. You can't leave it for next day, which many people will do because they can't see this on the table. And next day, entire cornea may be white, and you do anterior-segment OCT, you pick up descending membrane detachment. So on the table, I could inject air bubble for 3 to 5 minutes, attach the entire area, and surgery was complete. So such disaster can be avoided if you can visualize the things on the table also. So sometimes microscope may not be able to pick up very, very clearly under the hydrated wound. So if you do a little bit of descending membrane disruption is there, do a hydration of wound very, very meticulously so that you don't increase the descending membrane detachment in these cases. To summarize, IOCT microscope can give you the same picture as you do with anterior-segment OCT. So don't get that you don't have IOCT. Do anterior-segment OCT, you can picturize all type of surgeries. It started with the posterior segment surgeries, we have translated 100% utilization in a corneal surgeries for this. As Prabhakar talked about, the corneal surgery requires the visibility much more than cataract surgery, and it is, has a nice application in cataract corneal surgery also. And in refractive surgery also, we have done a lot of work in this. IOCT is very helpful in these cases also. Wide cataract, showed you the entire gametes. Posterior polar, yes. So these are areas where I think IOCT is going to be a future application to all the surgical microscopes, and that is going to help you to assess your cases beforehand, plan your surgeries, modify your surgery intraoperatively, and come out with a good outcome for yourself and your patients. And like to thank you, all of you, especially the organizing committee of Andhra Pradesh Ophthalmic Society. This is my, I think, fourth or fifth visit to Andhra Pradesh for various meetings, and I appreciate your help in a coming election for Vice President. Thank you for, again, wish you all the best.